me, and that was about enhanced myometrial vascularity, and it was how to treat it. So at this point, my answer to this is that basically you only have to treat this if it's it has a major symptom such as bleeding or other occurrence. In most cases, it is patient follow-up of this enhanced myometrial vascularity, because most of the time the reformatted uterine environment will go back to its normal pre-pregnancy status, and the vascularity will diminish. So don't rush to treat these by embolization or by any other means such as DNC and so forth, because most of these will recede. And there are articles that clearly say so. And again, the treatment should only be uncontrolled vaginal bleeding that endangers the patient's life.
Thank you. And Professor Timotrich, it takes a while. You need to explain to the patients that they need to be patient, because it can take months before the vascularity reduces.
Yeah, I think you are absolutely right about that. Okay, let's see if there is anybody else in the chat room.
Yes. I see some questions. Shall I wrote them down. Shall I mention one of the questions?
Okay, let's see what we have there.
Yeah, one of the questions: what is the effect of feedback on or a trial of labor on the cesarean scar defect and on the subsequent symptoms? And I maybe think Madalena can answer that question.
Yeah, do so.
Is Madalena still there?
Yes, I'm here.
Okay. Do you have any idea about the consequences of feedback in the women with a niche?
Okay, well, of course, when we have the finding of a niche and we know it before the pregnancy, we would avoid having a feedback in that woman. If we have the finding of a large niche and the woman becomes pregnant, I mean, we are lucky to know it. And also in women asking for a trial of labor after a cesarean section, we always make a ultrasound study of the area of the previous scar at the end of the pregnancy. We know that it's not like evidence-based. There are no clear cutoffs to use to allow a trial of labor, but we do it just to notice if there is any huge abnormality at the level of the previous scar. That's what I would say.
Okay. And to comment on that, Osama Naji from the group from Tom Bourne did a study on the effect of the niche on the chances of a feedback and successful feedback. And they so it is possible to have a feedback in case of a niche, even a large niche, but you have a higher risk of failure of trial of labor. We do have some patients that did not have symptoms before the vaginal delivery, that they developed after the vaginal delivery. So it is possible that in women with a niche, and if they have their second delivery as a vaginal delivery, that they develop symptoms, but they have no structural evaluation on this topic. So I think we cannot say what the prevalence is. Okay.
Is that for Madalena?
Sorry?
You want to answer this question, Madalena?
Which one?
About the feedback that Julie just.
It was just an additional comment from my side, so it was not a question anymore. So it's fine. So we can move on to the next question.
Thank you.
I can answer one of the questions that I see in the chat. I think I'm the one to answer them. And one of them is not treating an asymptomatic niches. Are we not increasing morbidity and mortality? Well, I think that if we do treat asymptomatic niches, we also may increase morbidity due to the surgery, because every surgery does require recovery and is related to a risk of symptoms. So that's the reason, if it's asymptomatic, that we do not advise to undergo surgery. But of course, we do not know yet if those women will have a high risk on placenta accreta spectrum or cesarean scar pregnancy or rupture. And this is one of the things that we're currently studying in a randomized control trial. So we randomize women with a large niche, even if it's less than 1 millimeter, and we randomize them between laparoscopic niche resection or expective management. So after this study has been completed, then we will know the beneficial effect of the surgery. But mostly we do advise them to undergo a primary cesarean section, so the risk of rupture is very low. I'm not sure if anyone else wants to comment on that.
I actually have a quick question, if I might, for you, Judith, and the Dutch group, and all this wonderful randomized trials you're doing. Can you expand a little bit on the technique you're using for laparoscopy and for repair in general? Like, we're going to talk later on about how you do a C-section to prevent an accreta, but have you learned anything about putting sutures in the decidua or not, or a large repair or small repair, suture types? There are many things I'm sure you're going through.
Yes.
Could you enlighten us?
Well, I would like to stress that the situation in a non-pregnant uterus is completely different than the suturing during the cesarean section, because the hormonal level is different and it's thicker, so it's not stretched. So what we do when we do a laparoscopic niche resection, what's very important is that we really remove all the scarring tissue. So the fibrous tissue has to be removed until it starts bleeding very nicely. And then the suturing, what we do is interrupted sutures, full thickness. We do not spare the endometrium. We take full thickness, and then we first place 4 sutures, and then we close the sutures, and then we apply a second inverting layer to reduce the tension on the wound. So a double inverting mattress suture. We use multifilament sutures for the suturing. And what's interesting, I'm not sure, we did a randomized trial in 2,300 women, in which we compared 2-layer suturing versus single-layer suturing after first cesarean section. And what we found is that 2-layer, single-layer, exactly the same, niches prevalence was the same, size was the same, symptoms were the same. But what we found is that, and it was not randomized for this, but if we used Vicryl, then there were less niches compared to the sutures from Brown. So there were also the multifilament. We found that if the residents performed the suturing, we had more niches than when the gynecologist did the suturing. So apparently good approximation and teaching of how to close the uterus, but also how to perform the cesarean section. I think that those are the most important things that we need to focus on. And after the laparoscopic niche resection, we apply an adhesion barrier. And this is also something that we studied in a pilot study so far after cesarean section. And we're now analyzing the results in a randomized trial to see whether application of an adhesion barrier reduces the prevalence of niches.
Thank you.
Okay, I will take the liberty to answer question 11 here. For women with cesarean scar niche who are undergoing IVF and embryo transfer, would you recommend hysteroscopic resection? So I think that it was clearly said, I think, by 2 of the presenters, that you only treat these if there are clinical symptoms and a real need for it. And I would direct the attendee who asked the question to an article by Gonzalez and Tulandi, who really looked in depth of this subject. I also will tell you that it is not rare that I see such repaired niches that they did not really change at all the residual myometrial thickness, and in another case, it made it even larger. And I always say that basically the repair will replace a scar with another scar, and I don't think that there is any literature about the increased danger of cesarean scar pregnancy if the scar is repaired. As a matter of fact, the repairing the scar is probably most efficient if one think about to prevent rupture. And I also have here another question that says...
May I comment on that, Ilan?
Okay, yes, and then I'll take the next question about the
In the systematic review that we performed in the literature so far, we found that after niche resections, the prevalence of cesarean scar pregnancy was approximately 1%, and they were mostly after hysteroscopic niche resection. And that makes sense because a hysteroscopic niche resection does not restore the anatomy, but it makes the niche only larger. So for this reason, you need to be very careful to perform a hysteroscopic niche resection if you do see a niche. And still, again, if you have a woman with a niche and infertility, we have to wait for the results to see whether a laparoscopic niche resection or vaginal niche resection improves the outcomes.
Thank you. Excellent. I have a question here that, because I touched this in my lecture, and the question is how to measure the residual myometrial thickness, transverse, sagittal. Do we need to keep the bladder partially filled? Sometimes we have difficulty in assessing this in acute anteflex uterus. We find it difficult. And do we have guidelines on how to measure it? Basically, I do have an article on that, and I also said in my lecture that the sagittal picture is not enough because basically the incision is made in the transverse fashion. So I think that going up and down in a transverse view will definitely find the area that is the most important to see the myometrial thickness. You have to have a high-frequency vaginal probe to do that, enlarge the picture, put the region of interest close to the tip of the probe in order to see clearly, and make multiple measurements, and don't be misled by the fact of report the thickest one, report the thinnest one. And I think that that would be the way to do that.
Okay, I think, and you mentioned now on the pregnant women, in case of non-pregnant women, and if you want to measure the residual myometrial thickness, then if you not clearly see it, then we advise you to apply saline or gel into the uterus to get a better image. And there is an e-learning on that if you're interested to know how to do it.
I think also that if you really measure the myometrial thickness in pregnant patients and want to follow it, there was, I don't remember already, there was an article that said that it changes, it gets progressively thinner, but if you start out with a thicker residual myometrial thickness, I think the outcome would be better. What do you think about that?
Yeah, I think that's the study from Osama Naji, from the group of Tom Bourne, I think. Or do you mean after? Do you mean in relation to surgery? No, just during pregnancy, right?
Yes, yeah. I do.
Yeah, that's a study from Osama Naji. They show that if it's decreased more strongly, then the success rate of feedback is lower.
There is a question here Should we offer all patients with a history of cesarean delivery who are interested in future pregnancy transvaginal sonography with or without saline infusion to assess the presence of a niche? That is a question that was not yet, I think, fully answered, but I think that it is not a mistake to do that. Patients are very much now informed about the possibility of a problem. So I think that, and I also have seen at least one article that says that we should definitely do it. The question in those articles was when to do it. Should we do it 3 months, 6 months, or a year after that? And I think that my personal opinion is yes, I think it's useful. Definitely patients who have multiple cesarean sections, and it can be done when the area is considered to be fully healed, and that is about 3 to 6 months after the cesarean section.
Yes, agree. Well, it's indeed in the literature it is there's still some difference between 3 and 6 months. So 6 months is the most safest moment to perform it, to be sure that it's not changing.
There were 2 questions here. Is the treatment of asymptomatic scar pregnancy indicated prior to IVF? I think that we answered that one. Can the severity of the niche increase in time? Judy, please answer that one. I don't think that it is, but I want to listen to what you say.
Well, the symptoms, the niches can become larger in time. So if there's a lot of blood accumulation, it might increase, but there are insufficient data to give the clear answer on that. I see here a question for Professor Janot. Why is the pass rate very low following myomectomy? Is this underreported or has the risk been overestimated in current literature?
So it's very simple because myomectomies are done in the upper segment where the myometrium is much thicker. And so you don't get this connection between the basal plate of the placenta and the peripheral circulation of the uterus. I mean, the rate of non-low segment, non-cesarean section placenta accreta is almost, inexistent, but it's overdiagnosed because anybody who's got placenta retention, especially in the US, will end up being diagnosed as placenta accreta when the placenta, can be removed simply by, a little gentle manipulation of the placenta with a forceps under ultrasound guidance. So there's a lot of overdiagnosis of the few cases that really exist. So unless you have a big damage that stays open like after a curettage that's not been repaired, there is no reason why you should have a placenta accreta in the upper segment.
Okay, thank you. I also see a question. What's the time span to recommend IVF after laparoscopic niche resection? Well, we advise our patients to wait half a year before they are allowed to try to become pregnant. It's not always necessary to have an IVF.
Who should answer that one?
No, I answered it already. So then we have one question. What should we tell our patients, a mother who incidentally find a niche? Yeah, we advise them, we tell them that they have a niche, but that there's no reason to do any surgery if there are no symptoms. But I'm not sure if Madalena provides the same counseling. Madalena, what do you advise your patients? You're on mute.
Oh, also, what I would like to ask you, Judy, to do, give me the number of the questions so I also see it. Where are you now with the questions? What number?
Well, I answered now question 20 to 25 and from 1 to 8, but there are still a lot of questions to answer, but we can also answer them in the chat. So I'm not sure if there is any other Speakers, are there any questions or things that they want to add to the discussion?
Yeah, I think that there is a technique that we can just take the questions and then maybe send it into our center, and they will give it because they know who asked the questions, and the questions could be answered in that way. And there is here a question that's interesting, is question 21. Is 2 millimeter RMT the valid cutoff of pregnancy, during pregnancy or outside the pregnancy? I don't exactly know what the attendee wanted to know in this case. In the literature in general, it's accepted that the danger of rupture of pregnancy during pregnancy is about 2 millimeters. But I also think that there is no final word about the cutoff thickness of the RMT that will reliably predict rupture. What do you think about that, Judy?
I think that the data so far are insufficient to really know the clear cutoff value. If it's below 2 millimeters, then you have a higher risk, but still we do not measure it structurally. And even if you measure it, I think you should measure it transvaginally to get an optimal vision. So actually, to be sure, we do need more studies to advise patients to undergo a vaginal delivery. And in our own center, we do not measure it before we offer them a feedback.
There also, if the question referred to, and once again, I don't know if that is in the first trimester, I think that the last article that I saw published by Kathy Spong was that she sort of I think that she was criticizing the article by the American Society of OBGYN, or she said that 1 millimeter basically is now the cutoff point that would be about the outcome of the pregnancy, and that was really heralding a bad pregnancy outcome. So the Society of MFM really said 2 millimeters or 3 millimeters, and she lowered that to 1 millimeter in her last article. I see that Eric wanted to say something.
Yes, one of the issues is that MFM people who look after pregnant women have very little exposure to gynae ultrasound. And so you have to take, their measurements and the way they evaluate the lower segment with a little bit of a pinch of salt. Because if they've never been involved in early pregnancy unit in terms of learning how to scan, it's very difficult for them to evaluate the lower segment. So you tend to have all sort of variation in the data depending on the gestational age, depending on how much of the placenta is inside, the scar. And so all these parameters, as you also said recently, need to be evaluated in much larger studies, including women being scanned before pregnancy. Because at the moment, all we have is about 90 cases, mainly case reports. So it's almost impossible to make any conclusion out of this.
Yeah, I agree on that. Vincenzo, you also want to add something?
Yeah, I have a quick questions for Eric and you, Judith. Eric talked about the pathophysiology, and others did. Inflammation, scar formation, lowering the uterus, more connected tissue, etc. So based on knowing more now, why the pregnancy implants there on the scar, could we come up with better adhesion barriers, and what adhesion barriers would be best? What can we do? Can we inject the anti-inflammatory agents? What can we do locally to decrease the chance of infection?
And you mean then decrease the chance on getting a cesarean scar pregnancy?
Yeah, Yeah, you said you place adhesion barriers. What do you
Yes,
think
but
the best ones? And
yeah, we do an adhesion barrier after cesarean section on the uterine wound after closure, just to prevent adhesions between the uterus and the bladder and the abdominal wall, because we think that adhesions right there might traction on the wound and induce less optimal wound healing, and therefore may be a part of the induction or the development of a niche. But that's something different from preventing a cesarean scar pregnancy.
Right. And I guess I'm pushing it, to the other side. What about, on the uterine side? Could we do something there to, prevent scar pregnancy?
I don't
know. There's no straight answer to that, obviously, but it's clearly linked to the number of cesarean sections you've had, because the more you cut the lower segment, and if you cut the skin at the same space, which is quite obvious, you can't cut the lower segment exactly in the same place. So you end up having more and more scar tissue, which also, join with the conversation about the repair of the scar, because the more you operate on that lower segment, the less myometrium there will be. So unless you can inject stem cells that regenerate the myometrium, which is still a bit of science fiction. I know that studies have been done on animal models, but they're not on humans. Until you can do that, you can't really repair. All you do with your stitches is to close the gap. And if you put your stitches in necrotic tissue from previous scars, it doesn't really close anything, just stops the bleeding, so the patient doesn't bleed out to the next cesarean section.
Yeah, but what we do with the laparoscopy, of course, there is a thin stretched part, and you cut out the thin part, and then you close the proximal and distal part of the uterus during your laparoscopic niche resection. So you do not need to remove much of the normal myometrium.
Well, you need at the edge. How do you put the edge together? Because the center has no myocyte, but it's that tissue.
No, you cut away the scarring tissue. I agree on that, and then you have.
So you have to reach the area that has healthy myometrial tissue. So by putting a stitch in there, you actually increase the area that's scar.
Yeah, that's true.
Because you damage the vasculature, which at the end is the main issue, is that the tissue becomes avascular and then becomes necrotic.
Yes, that might explain that we still have 5% failures despite optimal approximation of the wound.
I think
I would
probably also depends on where the scar tissue is, because if you cut very close to the cervix, you have very little tissue left.
Yeah, that's true. And most large niches are low located, and they are not always in the mid-sagittal plane, but also more on the side wall.
And then, if you look at the situation worldwide, you have so much variation in the rate of cesarean section and the number of cesarean sections. The Netherlands is probably one of the best countries to have a baby, because you have one of the lowest rate of cesarean section. And of course, the Dutch population doesn't have more than 2 children. But if you look at countries like Turkey or Egypt or Mexico, where they have 5 cesarean sections because they have 5 children, they have an incidence of cesarean section of 70 to 80% nationally. That's where, we probably should collaborate with these centers to follow up these patients and see what happens the next pregnancy. Because if you do that in most European countries, at least in the north of Europe, even randomized control study is going to take ages before you can have any conclusion.
That's true.
Okay, Davor, you are the expert of the first trimester. How do you relate to the residual myometrial thickness as the cutoff points in their measurements, and how do you advise patients, and whether you advise them to do a saline infusion or not?
It's a good question, because saline infusion, as Judith said, is going to change the perspective of niche and create almost different situation for physiology. So we're going to have slightly exaggerated impression the size of the niche and probably thinner residual mammature thickness than it would be physiologically. I'm slightly worried about scanning the niche because I look at women who come in the same menstrual cycle. Niche can look very different on day 10 of the cycle, day 15 or day 25. So there's a big variability in the presentation. Secondly, I'm not aware that we have done proper reproducibility study on niche measurement. Maybe Judy did, but I can't remember reading anything about that. Thirdly, haven't done much niche research, but I've been looking after scar pregnancies for many decades now, and there were hundreds of women who had serious scar pregnancies, very large niches, who fell pregnant, and I can't remember a single case of uterine rupture or serious complications. So I'm slightly worried about putting too much emphasis on residual mammature thickness because, as Judith and Eric said, uterine rupture is exceedingly rare. A large defect and thin mammature is very, very common, and I think we need to do a little bit more work and get enough data to actually have proper sensitivity specific study for the thickness. So at the moment, my approach is to women to say, yes, you have a niche, it looks large, and mammatum is thin, but the chance of serious complications is very low. And if pregnancy doesn't come in the scar, I think you're likely to be okay. It may be an approach which may prove to be wrong in the future. At the moment, I haven't seen any harm coming from that advice.
That's
I
very
agree on that.
interesting. In the United States at this point, I personally perceive the correcting the niches are in a commercial kind of an upheaval. There are so many patients who have niches that are much smaller than 2 or 3 millimeter residual mammature thickness, and they are advised to correct the niches. So I think that there is a lot of commercial standpoint that was taken, at least here in the United States, and I am trying to very unsuccessfully counsel patients in order to really consider correction when there is a clinical need for it.
I think we need to make a guideline altogether.
Yes.
On this topic.
Is that the same, Judy, in Europe, that you see that happening?
No, we always advise them, if there's no symptom, if there's no problem, then we do not advise them any surgery. And we follow them up, and we almost never see any problem. And we had one cesarean scar pregnancy in these women. So it's the risk on cesarean scar pregnancy is low. The risk on rupture is low, even in particular if you plan a primary cesarean section in case of a very thin residual myometrium. So therefore, we think there's, at this moment, without any evidence, no reason to do laparoscopic niche resection or a hysteroscopic niche resection to improve reproductive outcomes.
Judy, you have two.
Sorry. In the UK, we are discouraging repair of niche for reasons which you described before. But anecdotally, surgeons do not like sending patients back for ultrasound scans after niche repair, which is different from your studies and your practice. But from anecdotally, what I've seen, niche can be either better, can be the same, or it can be worse. So there is no guarantee whatsoever that the repair is going to make it better, and it's possibility. And I've seen women who paid a large amount of money to have niche repaired coming back and seeing their scar being bigger than before. So it's also the question of competence, surgical skill, and also auditing of the quality repair afterwards, which again doesn't happen in a routine practice in Europe, UK, probably in the Netherlands, also apart from your center of excellence.
Okay, Judy, you have two questions here. Question 32 and 33. Do you want to answer them? The 32 is, we must follow the classification described by Jordan and Judith of CSP in type 1, 2, 3A, 3B. And the second question related to this one was, what is your opinion about the natural delivery after laparoscopic repair? You recommend a minimal RMT or not? So
Well,
these are questions. Please answer them.
Yes. Well, the question, this is indeed the cesarean scar pregnancy classification, type 1, 2, and 3 it was. 1 and 2 are the same as have been published before and also used in the cesarean scar pregnancy registry. 1 is when the largest part is inside the uterine cavity. 2 is when the largest part is embedded in the myometrium. And 3 is when it crosses the serosal line. So if it's protruding towards the abdominal wall. I think that for us, it is important to differentiate if we have a cesarean scar pregnancy between vaginal or a DNC or between a laparoscopic niche resection. I do know that Davor thinks differently about this, and he will definitely discuss this later during this day. So I will not go into detail, but I think it also depends on the expertise that you have and the facilities that you have in your center. So for us, while we can do both laparoscopic niche resection and DNC, we think it's important to differentiate between type 2 and type 3. Then the other question, we so far after laparoscopic niche resection, because most women had already at least 1 or 2 previous cesarean section, and again a laparoscopic niche resection is again a uterectomy. So then we so far advised them to undergo a primary cesarean section. There are a few women who refused to do so and went for vaginal delivery, but we didn't dare to do it yet at this moment.
Okay, and there is a question here, number 36. Are the terms isthmocele and niche the same?
Yes.
I think that absolutely yes. It has 2 or 3 other names in the literature, and I think that the 2 most used was isthmocele and niche, and I think we should stick to the niche.
I think there's a very nice and maybe last question for Eric. Someone's asking, what would be the best technique to prevent a niche? Would it be an upper incision?
I think, yes, if you think about having one cesarean section, yes, maybe. But the problem is that, once you start having multiple cesarean section, you're damaging something that's going to become thinner and thinner with each cesarean section. So, you mean, if you look at, there are data on classical C-section, the upper segment, and it's another very nice American study, and showing like for the myomectomy that the rate of placenta accreta after that is extremely low, just because it's in the upper segment. And so, but you can't really start doing classical C-section in patients who want to have more than one C-section or more than one pregnancy.
Okay, I think that this question will be probably expanded upon and answered through the second part of the conference, when Dr. Anton will talk about the history of how cesarean sections developed and the closure techniques, and then Jess Myers from the same group will talk about one of the studies that were done. So the person who asked the question, please pay attention to the second part of this conference. Any other questions that we may not have answered? Judy, go through the questions from 1 to the end and see whether we really did answer the questions. I will leave you that task to do right now. Go slowly through them and see whether there is anything that we didn't answer. I don't want to upset the attendees because we still have a couple of minutes to...
Okay, I've seen one question, but I first give Davor his...
Which is the number?
I just want to follow on Eric's answer regarding the high incisions. It is very true that incisions which an upper segment tend to heal better. It is also very true that incision following myomectomy heal better. So it'd be tempting to conclude if we cut higher, we have less niches. But the problem is when incision in this area does not heal very well, then rupture during pregnancy is much more likely, and it's catastrophic. So therefore, I don't think the practice of cutting high would be rewarding, because at the end, I think we end up with more seriously adverse outcomes than we're having now. And also, it is much harder to diagnose abnormal implantation myometrium if pregnancy is an atypical location. So intramural pregnancy, which is typical consequence of myomectomy, is much more challenging to diagnose than scar pregnancy. So I would advise against moving your scalpel too high in the uterus.
I fully agree on that. I see one question. At repeat cesarean section, is there an argument to cut out scarred area on the uterus around the incision prior to repair? Well, no, but sometimes when it's very thin, when there is obvious and thin layer that makes suturing more difficult, then I remove the very thin layer to get optimal approximation, but we do not do this routinely. And then there, another question, since it is a keloid tissue, how about the use of ERP-YAG laser like we use in other scar tissue? I'm not sure for who this question is. I think Eric. He mentioned keloid tissue.
Yes, I think you can summarize the whole discussion in a few words. It's just basically, if you cut in the upper segment, if you do a myomectomy, for example, you tend to repair the space, and your risk is you try and rupture. Just Davor highlighted, I fully agree with him. If you cut in the lower segment, you're cutting in a tissue that has few myocytes. So whatever way you look at it, you're going to end up with large scar tissue, niche, isthmus cell, and your risk is obviously scar pregnancies and placenta accreta.
Okay. I agree with it. I have one question for Vincenzo. You mentioned the randomized controlled trial that you want to set up for in women who do not want to have more than 2 children, to have primary cesarean section or go for primary vaginal delivery. Did you thought about the possible infertility in women with a niche or after cesarean section? Because we found that in women with a niche, the odds ratio to get a live birth, it was 0.6 compared to women without a niche.
Thanks, Judith, for the question. Obviously, the idea of this randomized study it's a huge endeavor. There have been 15 randomized trials, as I said, and 2 are pretty big. The breach term breach trial and the twin trial, but they only had 2-year follow-up. They looked at urinary incontinence and things of that sort. They really didn't look at infertility. So I think that the question is still open. Yes, in our randomized trial, the aim is to follow to the end of reproductive life to see how many kids they have. Obviously, they would involve infertility issues. But this is a trial that we estimate will need 8,000 to 10,000 women, have 5 to 10 year follow-up, even if you start with a 35-year-old. Obviously women now have kids all the way into their 40s, etc. I'm glad, I wanted to bring it up here because I hope other people pursue something similar, including you who do a lot of randomized trials. These are difficult, but that doesn't mean they're impossible. That's why we involve pelvic floor disorder people. I think we'll have to involve infertility people. And there's a lot involved. I think maternal satisfaction, it's a big issue we haven't brought up yet today. But what makes, the woman happier in the end and healthier, obviously. But yeah, we have infertility embedded in that idea. And I'm glad I say that I proposed it to the NIH, but I also, like the Canadians who did the term bridge trial and the twin trial with follow-up, they're also interested in doing their own trial. So I'm hoping that a lot of different people look into this.
it would be interesting to at least ask the symptoms that were reported for the cesarean scar disorder, to ask these symptoms for the long term and to include them in your randomized trial. And we now developed an app, an e-health app, in which we ask women on their recovery. And it would be nice to ask to use that kind of app to get long-term follow-up easily.
If you don't mind, I will email you separately and your group, and anybody interested here, more than happy to help. You obviously are the leader in this issue, and it will be really important to, for our surveys, checkups, we're discussing, how often to follow them, every 3 months, more often, less often, what to do. And you'll be key into designing a proper follow-up. Thank you.
Thank you. Ilan, I think we had all the questions.